Thank you again for my next presentation, for inviting me. So, female patient, 67 years old. So, chest tightness for last 8 months, hypertension, hyperlipidemia, physical examination, and some clinical examinations showed no specific abnormalities. So, characteristic of the case is the middle segment of the LAD was almost occluded, and the stent could not pass through the lesion, and it fell off the proximal segment during withdrawal. So, mid-LAD nearly occluded curve and calcified lesion, and LCX 90% and distal 80% stenosis. So RC also 95% stenosis. So proximal RCA. So first we touch the RCA PCI. So guiding catheter BMW guide wire like a 1.5 to 2.5 balloons, pre-dilation done. So RCA PCI done smoothly without any complication. So most important things in the intervention cardiology, really a single second we don't know when the complication will come. So we find many normal case at the end, patients sent to ICU. So that's why the intervention cardiology is one of the most challenging profession in the whole over the medical career. So intervention cardiology, that means single second is very important and we don't know the future. So let's see the next slide. So we start with the LAD PCI, the EBU3 5 refers to the guiding catheter and the XTR is exchanged after the BMW guide wire is exchanged. The 2.5 semi-compliant balloon were pre-dilated for the multiple times for easy access. So the 2.5 stent failed to pass through turning point and fell off into the proximal segment of the LAD during retraction. Then all the problems starting in that point. Then 1.5 balloon is sent to the unloaded stent and dilated repeatedly. So we told every time like a 80% solution came through the small balloon, very cheap, very easy, and time consuming, and feel safe for the patient as well. So 2.5 balloon was sent to the unloaded stent for the multiple expansions. So contrast showed the distal dissection and the 2.5 stent was fed to the unloaded stent for release. The LAD stent adheres to the wall very good. The distal blood flow, TME3 grade 3, done. So what is the summary? The stent unable to pass through the mid-LAD lesion and falls into the proximal segment of the LAD when withdrawn. So that is also one of the trouble we face. The diameter of the stent can be correspond to the lumen of the proximal vessel. The small balloon expands progressively to release the diluted stent for the proximal segment. Tortuous stenosis calcified lesion required adequate pre-treatment. So proximal vascular tortuosity may be considered for early use of an extension catheter. So number 2 balloon test passively and generally gently push and retract to the stent is one of the most important technique. So 75 years old male, intermediate chest tightness for 1 year, then aggravated for last 1 month. Inferior MI before 1 month, thrombolytic treatment in the hospital done. So previous hypertension, diabetes mellitus, old cerebral infarction, gallstones, all the disease with him together. So what is the characteristic of this case? The balloon ruptured when the stent was released and fell off when it was withdrawn. So there is no severe stenosis in LAD and LCX. So distal RC is 90% stenosis. So GR4 guide tube is unsupported and we convert to the Godzilla. So 2.5 balloon pre-dilatation done. When the 3.25 stent is released, the balloon ruptures occur immediately. So then we need to think what to do and how to do. So again, a 2.5 pre-dilated balloon and 3.5 post-dilated balloon were put into the C2 dilated deluged stent area and continue to implant at a 3.25 stent at the lesion. So there is no dissection, no hematoma, distal flow is TIMI-3 after the stent release. So the balloon ruptures when the stent release falls off the middle of the RCA when it withdrawn. And it in situ release of the dilated deloaded stent, there is no need to force withdraw from the body. Coronary blood flow is the first priority. So tortuous vessels should be treated with an extension catheter as soon as possible. When using Godzilla, be especially careful about scratching the stent at the hypotube interface. So that is all of the summary, but what is the summary from our side to the intervention cardiologist? Stent loss, balloon loss, guiding catheter loss. This is the very common procedure complication in our daily routine. The most important is we have to know what is the facilities we have in the intervention cath lab, because many trouble when it starts, we cannot find the right instrument at the cath lab. So before we start the procedure, is a very routine check by our team, what stent, what balloon, and what is the instrument we have available in the cath lab. Thank you again for inviting us. Thank you, sir.
Thank you.